So we're going to talk about pancreatic cancer and hopefully hear about some new developments that may be encouraging for the future here. We have Dr. Lucio Gordon from the FCS as our co-moderator today. Lucio, anything you want to just start out with in terms of throwing out some general questions about pancreatic cancer?
Happy to. I have a burning question here. Two patients I saw recently, both patients were athletic, young, robust, and well-versed in science, like this audience here, maybe this part of the audience here. But so the question is, they presented with a localized cancer. One person had a clearly resectable tumor, and the other one had a borderline resectable tumor. So how does the panel here address neoadjuvant approach? Do you do like a total therapy, neoadjuvant chemo, followed by chemoradiation, followed by surgery, or do you do chemotherapy followed by surgery? What's in your mind in your centers?
So Andrew, and what specific therapy in addition?
Yeah, well, this is a pretty common scenario that we encounter, and certainly for borderline resectable disease, where I think it's unassailable that you start with aggressive chemotherapy, our treatment paradigms are actually shifting even for resectable disease, and this really required our surgeons to get on board, which they very much are, that even for patients with technically operable pancreatic cancer from the outset, we are almost uniformly taking those individuals and starting them with neoadjuvant chemotherapy. Our institutional approach is a total neoadjuvant approach. This is certainly up for debate. My reasoning for that is that, and what I tell patients is, listen, you're going to require a full course of chemotherapy, 6 months worth. Why not front load it so that at the point where you get to surgery and your postoperative recovery can focus on just your rehabilitation improving without necessarily needing to get additional chemotherapy afterwards. So using, for example, a modified FOLFIRINOX regimen, which we would for a young fit patient, we'll try to front load as much or all of that chemotherapy as possible.
So Eileen, this patient jumps on a plane, goes to the other side of the country and says, hey, I heard some interesting things from Dr. Ko, but what's your approach to this?
Yeah, I think for borderline resectable disease, complete consensus, guidelines, expert opinion, neoadjuvant, potentially a TNT strategy. I do think it's a much more nuanced discussion, though, for resectable pancreas cancer. So for a small tumor, low CA19-9, fit individual, no question of anything anywhere else. You know, the level 1 evidence would support surgery first and adjuvant FOLFIRINOX. That remains our standard, and I do think we have some intriguing data on immunotherapy coming in this space that might also support that paradigm. But yes, for sure, if it's a high CA19-9, if there's an iffy lesion in the liver, you're not sure, if somebody has comorbidities, then yes, indeed, I think a neoadjuvant approach is more than reasonable. And we have two major studies coming, one from Europe and one from the US, that are going to read out at the same time that may also inform our approach for the truly resectable pancreas cancer patients.
So whenever we heard very interesting and immunologic and pancreas in the same sentence, I've got to ask you, what?
Yes, so coming, and we'll touch on this in the...
these vaccine things?
Yeah, I think there is some interest and is some data to be validated, of course, but exciting that we might see an immunologic signal in an unselected group of patients with pancreas cancer, either using a personalized neoantigen approach or maybe a KRAS-directed vaccine approach.
So, Lucio, any other questions? And also, I'm kind of curious, how do you, in your practice and your surgeons, how are you approaching resectable disease? Are you sending them to surgery, or more Andrew's approach in neoadjuvant?
So specifically in our center, we have a surgical oncologist that deals a lot with complex surgery. So we do what was said with neoadjuvant chemotherapy, and if the patient tends to have a more kind of borderline resection, can we really do it from a surgical standpoint? We do the TNT therapy, but for me, the data is hard to discern what to do, just pre-op chemo or total therapy, and that's where I was trying to get at.
Any other questions you want to throw at them before we take a look at some of these data sets?
Yeah, how do you guys manage oligometastatic disease? Do you address like somebody with 2 liver lesions? Do you go after with RFA surgery, or is this a nihilistic view of pancreatic cancer that is totally metastatic, it's not worth going after small lesions and then systemic therapy?
It's funny watching the two of you. You both sort of smiled when you said oligometastatic. So Eileen, I take it that you like the topic.
I definitely like the topic, and I think it's one that's gaining some traction and a lot of interest. And we had a study that was presented at the GI Cancer Symposium a couple of months ago looking at primarily a radiation-based approach for oligometastatic pancreas cancer, suggesting, lots of limitations of the study, but suggesting there may be a subset of patients who benefit. And more than anything, what I like is that we're now beginning to study this question, and we'll generate data and understand whether we can actually recommend a liver-directed approach, a radiation-based approach, microwave ablation, resecting. I do think, like all solid tumors, there is going to be a subset of patients where a local therapy can have value, but it's not the first thing you do when a person presents with advanced disease.
So back to Lucio. Any other questions? Any adjuvant questions or anything you want?
Yeah, I think the adjuvant question that still persists in America is that, let's say, to your comment, Eileen, that patient had a small lesion and then went to surgery directly and then adjuvant chemotherapy. What do you do with radiation? It's an old question that persists. Do you radiate an N0 patient or only an N1 plus?
Yeah, so thanks for raising this. I think, again, a topic of lots of discussion and perhaps no consensus, and still kind of a wide range of approach in terms of how to manage. We're waiting for RTOG 0848, which completed almost 7 years ago now, I think. Maybe, Andrew, you'll correct me, but a good length of time. So hopefully we're going to see that data this year. That might add to whether or not we should routinely recommend radiation. Selectively, we use it for patients with margin positive in the post-operative adjuvant setting after systemic therapy, not before. And we use it selectively in neoadjuvant therapy. Although I do think for patients with locally advanced disease, I think there's a significant role for radiation.
So I want to get to the first talk, but I thought I might throw in a question. You've probably heard this a few times over the years, Andrew. What do you think outside of clinical trial, what do you think the optimal first-line therapy in metastatic disease is? I actually thought I knew the answer to that 6 months ago. Now I'm not so sure. I don't know if it even matters, and I know you're going to go into it, but before you get into the data, just sort of macro, bottom line.
For the fit patient, meaning ECOG of a PS of 1 or even borderline 2 patients, up to age 80, my standard of care remains FOLFIRINOX, and actually the modified version of FOLFIRINOX. I'll share some data, obviously, that raises some questions about that, but as of this point, that is my go-to frontline standard.
And what other alternatives would you think about?
Well, obviously, we have what I'll talk about patients with is options 1A and 1B. And option 1B, including the combination of gemcitabine and nab-paclitaxel. We and I will share some data with this newly approved regimen called NALIRIFOX that Dr. O'Reilly and colleagues were very instrumental in bringing to the forefront. And I think we'll all be grappling with how we might incorporate NALIRIFOX, which is basically substituting nanoliposomal irinotecan for the free irinotecan in the FOLFIRINOX regimen, where there's some compelling level 1 evidence.
And again, just curious how you answer that question nowadays, Eileen, particularly about the issue of whether it's FOLFIRINOX or NALIRIFOX, versus GemNab.
Yeah, I think it depends on what the individual choices are, whether it's trial options or not. But if we'll take it outside of a trial setting, for a fit individual, yes, modified FOLFIRINOX, or a discussion whether we should think about NALIRIFOX. I think that's clearly on the table. mostly in this setting, will deprioritize gemcitabine nab-paclitaxel to a second-line setting. But the world is changing, and we have some biomarkers that suggest that neither modified FOLFIRINOX or perhaps NALIRIFOX will be optimally suited for a subset of patients. And for those individuals, even though they may be ECOG 0, we may end up recommending gemcitabine and nab-paclitaxel. The Japanese data, which I'm sure Andrew is going to present, is a little confusing, but I don't think it changes practice in North America, and we don't have a mature data set yet to fully interpret.
So, Lucio, I'm curious how you think through first-line therapy and what you thought about the NALIRIFOX data.
Yeah, so statistically speaking, most of us do use modified FOLFIRINOX. We are getting now with approval NALIRIFOX up front. I have had 2 patients that have done that even before approval. I have the sense that tolerability was a little bit better. So I think it's going to get more mainstream, and there are issues with costs and approval and other nuances there. But I think it's going to pick up a little bit.
All right, Andrew, let's take a look at the data.
Great.
Actually, you got a case, I think, too, right?
Yeah, thanks, Dr. Love. So I'm tasked with discussing the selection and sequencing of therapy for patients with metastatic pancreatic adenocarcinoma, which we've already touched on, but I want to dive a little bit into the data here. And I'll start with, after showing these disclosures, a case presentation. And this is fairly typical for what we see in clinical practice. This is a 72-year-old gentleman, presents with abdominal pain and progressive fatigue. This diagnostic CT you see on coronal images shows a pancreatic body mass, retroperitoneal adenopathy, and hepatic lesions, one of which is biopsied and demonstrates invasive adenocarcinoma. As we now do routinely up front, we send the sample for NGS, and his tumor harbors pathogenic mutations in KRAS, so specifically G12D genotype, as well as CDKN2A, a somatic BRCA2 mutation, which he also carries in his germline, and the tumor is microsatellite stable with a low tumor mutational burden. So we'll talk a little bit. I'll start, and then Dr. O'Reilly is going to talk in even greater detail about how these results can guide therapeutic decision making.
Can I just ask how you think through that case? And I'm curious how Eileen would too, but how you thought through it.
Yeah, so I will say that first and foremost, we look at clinical parameters and factors in making this decision, as well as shared decision making with the patient at his age, comorbidities. He's in pretty good shape overall. I don't point out here, but his ECOG performance status is 1. And so as I mentioned before, I will talk to him about a couple of different options, but my go-to standard remains a modified FOLFIRINOX regimen. We will not typically have the molecular profiling results back in time. We certainly don't wait for that before deciding on treatment. So absent that data, this type of patient, I would typically start with a modified FOLFIRINOX regimen.
And I guess, Eileen, if you knew the patient had a BRCA mutation, and prior to that time, what would you be thinking, first of all, in terms of the chemo you'd be using, because certainly they would be platinum sensitive, you've shown, but also, if you could, would you want to bring in a PARP inhibitor?
Yeah, thank you. So I would agree with Andrew that modified FOLFIRINOX for an ECOG 0 or 1 individual would probably be our preferred choice. We have 2 DNA damaging approaches with both the platinum and irinotecan. If the person was less healthy and we knew that they had an oncogenic somatic or germline pathogenic BRCA mutation, then I think cisplatin-based therapy with a doublet of gemcitabine is reasonable and supported by the data. And yes, certainly a discussion after disease is debulked and stabilized about whether to integrate a PARP inhibitor. But yes, I think it's a nice option for these patients.
Lucio, any questions?
Yeah, so I have N of 1 or 2 in a patient with a germline mutation for BRCA, and we're trying to obviously check every patient with pancreatic cancer for somatic and germline mutation. And we did the usual chemotherapy followed by olaparib for these patients. Good tolerability, response is hard to measure because she had relapsed within four months. But question I have is how well is this olaparib tolerated in your practice? And the second question on PARP inhibitor that kind of gives me some itch is, Are you trying to incorporate, or is there any data of olaparib in the neoadjuvant setting for patients who have BRCA?
Eileen, and we were talking on Friday night, there was a neoadjuvant trial in breast. It was at 50% path CR, but it was never followed up. Any thoughts about Lucio's questions?
Yeah, thanks. I think it's an intriguing one. So the best data we have to inform this is both the POLO study and a study looking at single-agent olaparib at disease progression. And response rates are in the 20s, which is about half of what we'll see with combination chemotherapy. And in the neoadjuvant setting, where you need as much advantage from the treatment as you can, it remains to be seen whether that would be a reasonable alternative. I also think there are more patients who respond to platinum-based therapies than respond to PARP inhibitors. So probably not, except maybe in an older patient or somebody with a lot of comorbidities where chemotherapy just wasn't a feasible option.
And
Go ahead, Ann.
yeah, I'll also point out your question was the neoadjuvant setting, but I want to shout out an ongoing cooperative group trial that is actually looking at a PARP inhibitor in the adjuvant setting. So following surgery, neoadjuvant or adjuvant platinum-based chemotherapy, a study that is looking at the use of olaparib versus placebo in that context. Don't think we're quite ready to incorporate a PARP inhibitor into the neoadjuvant setting just quite yet.
Would you be willing to offer adjuvant PARP to somebody outside a trial?
I tend to be fairly by the book in this situation, so until we really have compelling evidence that that can improve disease-free survival, at least I would not use a PARP inhibitor in that context.
Second opinion? Eileen?
So I agree with Andrew, all for answering the question part of the trial, but have I done it? The answer is yes. It's honest.
All right. Let's go ahead and take a look at some of the data you want to present here.
So clearly for this patient I presented with metastatic disease, chemotherapy remains the mainstay of treatment. And it's hard to believe these data are now more than a decade old, but the pivotal study that led to the approval of FOLFIRINOX as first-line treatment for metastatic disease is now more than a decade old and really demonstrates here, as you can see from this Kaplan-Meier survival curve, a significant and clinically relevant improvement in not just overall survival, but PFS, response rate, one-year survival, compared to the erstwhile standard, which was single-agent gemcitabine. And I always like to show contemporary data that with FOLFIRINOX in the current day and age, we've probably exceeded 1 year in terms of median survival for this patient population. Now, the other, as I said, option 1B for this patient population is the combination of gemcitabine and nab-paclitaxel. This is the MPACT trial, which was a more international study, a global study compared to the FOLFIRINOX data, which was limited primarily to French academic sites. And the results perhaps not quite as impressive as the Prodige French trial with FOLFIRINOX, but still significant benefits in terms of overall survival, PFS, and response rate compared to gemcitabine alone. And again, if you look at more contemporary data, you see that gem-nab-paclitaxel hit a median survival of almost a year or so. So clearly we have these two very good options as frontline treatment. And for quite some time, we asked, well, can you compare these? And we'd always say from an academic standpoint, well, you can't really do cross-study comparisons. It's not quite valid. But I still show in tabular fashion here a comparison of FOLFIRINOX and gem-nab-paclitaxel based on the published phase 3 data. So you just see some differences in terms of the patient population. Gem-nab-paclitaxel did include patients up to their mid-80s with a slightly poor performance status. You see differences in growth factor support and some, I'll say, modest differences in grade 3/4 toxicity, but perhaps not as much as you might think for what we think about with FOLFIRINOX being a more toxic regimen compared to gem-nab-paclitaxel. But we've asked for a long time, well, do we have any head-to-head data? Will that study ever be actually available? And the answer is yes. We now have results from this JCOG. So this was a Japanese study. For those of you who may not have gone to ESMO in Madrid last year, I thought this was very intriguing data because it really was the first direct head-to-head comparison in a phase 3 study comparing gem-nab-paclitaxel to modified FOLFIRINOX for the frontline treatment of metastatic pancreatic cancer. I'm going to ignore this third arm of S-IROX, which in Japan, S1 oral fluoropyrimidine is used quite commonly, and that represented a third arm. But if you look at the primary comparison between gem-nab-paclitaxel and modified FOLFIRINOX, the results were, I'll say, surprising to many of us. You look at the overall and progression-free survival, and there was, at the very least, no difference between gem-nab-paclitaxel and modified FOLFIRINOX, or really what appeared to be some trends towards improved outcomes with gem-nab-paclitaxel in this Japanese patient population. So really quite striking and surprising results, also noting that a median survival of, say, gem-nab-paclitaxel in this study was 17 months. So really almost unprecedented in patients with metastatic pancreatic cancer. And so trying to interpret these data, I'll say it was terminated for futility after pre-planned interim analysis showed, because the study was designed and powered to try to demonstrate a clear superiority of FOLFIRINOX over gem-nab-paclitaxel. And that clearly wasn't going to be the case. As I pointed out, gem-nab-paclitaxel, if anything, looked better, or the best out of these three arms. And so the investigators concluded here that, hey, gem-nab-paclitaxel should represent the first-line standard for metastatic pancreas cancer. Very different from what any of us on stage said beforehand, where our current standard remains modified FOLFIRINOX. A little bit of a head-scratcher. It raises questions about, well, how does the Japanese patient population differ from, say, a Western patient population? We obviously don't have biomarker data from this study that helps guide us here, but I think it just raised a number of provocative questions. So let's add just another, I'll say, confusing point to the mix, and that's the NAPOLI-3 trial that Drs. O'Reilly, Wainberg, and others published recently in Lancet. This is basically taking nanoliposomal irinotecan, which is currently approved for the second-line treatment of metastatic pancreas cancer after a gemcitabine-based regimen, and said, hey, let's move this into the frontline setting. Let's substitute free irinotecan and put in Naliri in its place. You'll note here the doses of NALIRIFOX, the oxaliplatin dose is a little bit lower than we typically give with a modified FOLFIRINOX regimen at 60 instead of 85 milligrams per meter squared. But this international phase 3 study was a comparison between this NALIRIFOX regimen and gem-nab-paclitaxel. And what was demonstrated in this study is a statistically significant improvement in overall survival with using NALIRIFOX compared to gem-nab-paclitaxel, with a median survival of 11.1 versus 9.2 months, also significant improvement in median progression-free survival, and very similar response rates with both of these regimens. So when these data came out, it obviously produced a fair amount of discussion and debate, because if you look at these NALIRIFOX data compared to the historic FOLFIRINOX data that I showed previously, you couldn't get a more identical median survival if you tried. 11.1 months for NALIRIFOX, 11.1 months for the older FOLFIRINOX data. You could say that there were maybe some numerical improvements in median PFS for NALIRIFOX, as well as objective response rate, maybe some nuanced differences in the grade 3/4 adverse event rate. But really, with identical survival outcomes, I think this raises relevant questions in terms of, well, for patients in whom we previously were going to be using modified FOLFIRINOX for, should we be routinely substituting NALIRIFOX in its place? And so it brings up the question, well, where does this exactly leave us in terms of the selection of chemotherapy for our pancreatic cancer patients? I just showed this NAPOLI-3 data. So if you do the greater than and the transitive property for these studies, well, we see that NALIRIFOX is better than gem-nab-paclitaxel, but NALIRIFOX appears equivalent to FOLFIRINOX based on historic data. And yet you have, in granted a different patient population, gem-nab-paclitaxel appearing to be equivalent, if not superior, to FOLFIRINOX. And so I will say that we're at a point right now where, with just the recent approval of NALIRIFOX a month ago for the frontline treatments, I think all of us who see a lot of patients with pancreas cancer in addition to thinking about clinical trial design and what chemotherapy backbone or reference standard we should be using in clinical trials, I think this is what we're going to have to be thinking about and grappling with in the months and years to come. Now,
Just speaking about grappling with it, as long as you brought it up, and I mean, people are bringing this up all in the chat room. John Layton also bringing it up. So, just kind of curious, Lucio, how do you compare quality of life, with modified FOLFIRINOX to GEM-NAB? And if you become convinced, there's really maybe it's hard to tell I don't know what you think about what you just heard. I'd seen the slides, but I hadn't heard somebody explain it to me. What are you thinking right now, Lucio?
To me, it's Coke or Pepsi. I like Coke better. But anyways, they're very similar. We're talking about very mild nuances of survival. So
what about quality of life, though, and inconvenience?
Gem-nab-paclitaxel, in my mind, is much better tolerated. Convenience-wise, it's not the end of the world to come to the clinic twice a month. The pump issues, etc. So I don't have a problem with gem-nab-paclitaxel.
Do you find it more interesting since seeing this data from ESMO?
I do.
I did. I was like, when I saw that, I'm like, what?
Yeah. It just changed a little bit.
Keep going.
So one question is, can predictive biomarkers or genetic signatures allow for more rational decision making? There are multiple lines of evidence supporting the use of platinum-based therapies, as Eileen mentioned before, for patients with HR deficient, so homologous recombination deficient pancreatic cancer. So as characterized by, say, BRCA or PALB2, but actually even non-core HRD pathway mutations such as ATM, RAD51, those mutations in this HRD pathway, if your patient has a tumor that harbors one of those, they should ideally receive platinum-based therapy at some point during their treatment course. Because this, what I show here is just one of now multiple lines of evidence that is fairly unequivocal in terms of suggesting that these patients do clearly benefit from such an approach. And in terms of platinum-based therapy, I'll just say this applies to both oxaliplatin, such as what is received in FOLFIRINOX or NALIRIFOX, but also cisplatin-based regimens, such as gemcitabine and cisplatin. I share here the randomized phase 2 study that was published by Dr. O'Reilly and colleagues, looking at gemcitabine and cisplatin with or without a PARP inhibitor, and that's the addition of a PARP inhibitor in this context for patients was not beneficial, but if you just look at the whole cohort of patients receiving gem-cis as a chemo backbone, look at this waterfall plot. I mean, it's incredibly robust in terms of seeing very high objective response and sometimes very deep responses using this as a chemotherapy backbone. And as a matter of self-interest, I just want to give a shout out. This is a cooperative group study that I have the privilege of helping to lead. This is for the second-line treatment of patients with metastatic disease with either somatic or germline BRCA or PALB2 mutations. Asking the question, well, maybe not all platinum analogs are similar. So patients who receive FOLFIRINOX in the frontline setting, with or without a PARP inhibitor, at the point of progression, we're testing the hypothesis that continuing with a different platinum agent in the second-line setting, so looking at it in the context, we haven't really talked about this, but a 3-drug combination, GEM, nab-paclitaxel, and cisplatin, which has shown very promising evidence in the frontline setting. We're looking at it now in the second-line setting. It's been looked at in biliary tract cancers as well. Comparing that to what I think is our usual go-to second-line standard, which is GEM, nab-paclitaxel. So this study just recently opened. I just want to bring it to the audience's attention to highlight this and would love you to refer your patients for this study. Okay, in the interest of time, I'm going to wrap up in the next couple minutes. I just want to touch upon second-line treatment, and this is to note that, again, for patients who started with gem-nab-paclitaxel, we have level 1 evidence of using Naliri plus 5-FU-leucovorin, or sometimes I'll use FOLFOX or CAPOX in the second-line setting as well. Conversely, for patients who started with FOLFIRINOX or now NALIRIFOX, typically we'll switch to gem-nab-paclitaxel. I'll just say, practically speaking, in that second-line setting, I typically use an every other week schedule for better tolerability. For robust patients, I'll also include cisplatin in that mix. And what I want to highlight in this schematic in terms of sequencing front and second line treatment is there's actually a number more aspects here, and that includes maintenance therapy. It includes using the information we get from next-gen sequencing and germline testing to inform what is more second-line treatment options for those rare genetic findings that can inform more nuanced and targeted therapy approaches. Just a word about maintenance therapy. Dr. O'Reilly is going to talk more about olaparib and the POLO trial data. But for the majority of patients who don't have a BRCA or PALB2 mutation, for patients who receive FOLFIRINOX, it's quite typical after a period of time, 6 months or so, to de-escalate their treatment to something simpler. I tend to use capecitabine as monotherapy. For patients getting gem-nab-paclitaxel, I might simplify it to single agent gemcitabine. Or, as we talked about before, for oligometastatic disease, after a period of time, that might be the right context to think about ablative radiation for limited sites of metastatic disease. I just want to show this single table because Eileen is going to talk about this in greater detail. But I mentioned that when we do that next-gen sequencing up front, when those results come back, I tell patients, listen, most of these findings are not going to be able to inform treatment. It's good information, but it's not necessarily actionable yet. And I just show sort of the incidence in pancreas cancer. We talked about HRD-associated mutations, but there are a host of other ones ranging from G12C to high microsatellite instability and others that occur in 0.5%, 1.5%. But if you find those, they can actually be very therapeutically relevant, as Eileen will talk about. And so I'll close here in terms of what I consider the outstanding issues in the treatment of metastatic pancreas cancer. And maybe it's kind of fitting that we're the last session because you've already heard from a lot of other disease types how we're able to subclassify and have a number of different treatment options for different slices of individuals who have breast cancer or non-small cell lung cancer. And we're not quite to that level in pancreas cancer. Right now, our decisions are still primarily based on clinical criteria, as mentioned, age, comorbidity, even patient convenience, and just that shared decision-making. But I think we do have some emerging evidence for at least a few molecular genetic subtypes, granted at very low incidences, that may help guide a selection of therapy. And I will stop there.
So we're going to move on and have Eileen talk about some of the new directions, but I actually want to start out with your case, 52-year-old woman. What happened with her, Eileen?
Yes, so thank you. So this is a youngish lady who had a family history of germline BRCA and presented with back pain, had a rising HbA1c, underwent a workup and identified to have a tail of pancreas primary, multiple liver metastases, moderately elevated CA19-9. We actually didn't know the germline status at the time of diagnosis, but strongly suspected based on the family, and that indeed did turn out to be correct. Had a germline BRCA2 mutation and had very typical somatic genetics with a KRAS G12D mutation. So had a nice response, felt better pretty quickly on treatment with modified FOLFIRINOX. And then going to this question of maintenance therapy, which is now, I think, increasingly a reality for patients. And should we continue chemotherapy? Should we take a break? This comes up quite a lot. PARP inhibitor or KRAS-directed therapy, which isn't quite today for this genomic setting a reality, but as Dr. Coe was alluding to, is about to be, I think, in this disease. So what would you do, Andrew?
Well, as of this point, if this patient has had a good response, I typically like, even though the minimum is 16 weeks before patients can go on to a PARP inhibitor, I like to treat, as if a patient is tolerating well, I like to treat to maximal remission, I have to say. So I'll aim for 12 cycles, and there's nothing magic about that, I tell patients. If they're tolerating well, if you're still seeing them on the trajectory of response, I might even push forward until they plateau in a response. And at that point, segue to a PARP inhibitor.
I guess these people respond pretty well.
They do.
Maybe chemo.
One other point to think about in the decision-making is platinum resistance is a very high surrogate for resistance to PARP inhibitor. And so to some degree, the longer you treat, you may actually lose an opportunity to integrate a de-escalated form of oral therapy for patients. Mm-hmm. So what the sweet spot is, I don't know, but it's probably somewhere between 4 and 8 months in terms of making that transition for most patients.
That's a great point.
Yeah.
Please continue.
Yeah. So continuing and just picking up exactly on what Dr. Coe introduced, so still the majority of patients, are in the left box there, or your, yes, the left box for you, but increasingly we think about subdividing pancreas cancer, and just a shout out for the KRAS wild type. This is a small subset, it's younger patients typically, no RAS mutation, about a third will have other actionable alterations. This is where we see the rare fusions, NTRK, NRG1, MET, etc., for which there are drugs available in other indications. We also see an enrichment of MSI high in that subgroup. So think younger patients, no KRAS mutation. You need to look hard for these fusions, and that requires RNA and other, sometimes IIC, complementary testing. We'll come on in a minute to both the BRCA-related subgroup, and also discuss in a little bit more detail what's happening in the KRAS space. So moving to the synthetically lethal therapy, just a reminder here, it's beyond BRCA1 and BRCA2, and we test patients with pancreas cancer for germline alterations for the therapeutic application, but also for their family. We see about 10 to 11% of patients with germline alterations, BRCA2 being the most common, followed by BRCA1, but an important subgroup is ATM, not a HR gene as we know it relative to BRCA2 and BRCA1, but biology may be a little different. Those patients may do better, may respond more to irinotecan-based therapy. So just keep that in mind in terms of testing. So what do we know about BRCA1 and BRCA2? This was a nice analysis from Kim Reispinder and her team at Penn, looking at an international collaboration of outcomes in this disease. And if you look at the top graph, and I'm sorry, it may not project so well, it's looking at patients who had resectable disease versus those that did not, and BRCA2 versus BRCA1. In general, BRCA2 does better, and we're increasingly seeing that. It may be also more immunogenic, and we'll come back to that in a moment, and maybe the group of people who get the best outcome for platinum-based therapies, and that's also supported on the bottom graph. This is not prospective data, though, so there are caveats here. I'll skip over this in view of time because we've discussed it, and just go to the POLO study. So brief reminder on this. This was for patients with germline only, BRCA1 and BRCA2, had to have at least 4 months of therapy, 3-2 randomization, double-blinded for olaparib compared to placebo, and the primary endpoint was progression-free survival, and that was clearly met, doubling of progression-free survival for the olaparib-treated individuals relative to those that did not. And then as we look at the later term outcome, and this again, apologize, it may not project so well, it's looking at the third cutoff, which is the latest cutoff, looking at overall survival. There wasn't a difference in overall survival, and part of this is probably small patient numbers, probably crossover that happened subsequently, and just would take a much bigger study to power a survival question. But I do think it's fair to note that for patients who did receive platinum and a PARP inhibitor, their survival curve did track better over time, sort of suggesting that maybe individually there is an improved outcome. What about safety for PARP inhibitors? No new signals across this study. Anemia, fatigue, and a little bit of GI toxicity, particularly early on. There was no MDS observed and no secondary leukemia in this particular cohort, and to my knowledge, none still, even with longer follow-up, so good to know. So coming back to this question of subsets of patients and in whom immunotherapy may work, the 1% of people who have mismatch repair deficiency, that's established, and these drugs work and work well in pancreas cancer despite initial data suggesting maybe otherwise. But I just point this out, this was a group of patients with both pancreas and hepatobiliary malignancies who received ipilimumab and nivolumab any line after they had progressed, and it was, again, a retrospective cohort analysis, and there were a few striking responses in terms of durable outcome. And so what's behind that, we don't know. We know that patients with BRCA2 in particular may have higher levels of PD-L1, slightly higher TMB, more chromosomal instability, and may benefit more from platinum-based therapies. So I'll just pick up again on what Dr. Koh mentioned, the Apollo study. So it's not a question of PARP inhibitor versus placebo. It's after people have received all of their standard therapy. They got a neoadjuvant, adjuvant, platinum, non-platinum, doesn't matter. So it's a very simple, very straightforward question. And it's a 2-to-1 randomization. That's about getting close to 40% or so accrued, so a little bit to go. There's an Alliance and SWOG study, led by SWOG, I should say, looking at PARP inhibitor plus or minus immunotherapy in the maintenance setting. And Dr. Koh's study is at the bottom. I just have to change my slide. Sorry, it's in my brain, SysGem for BRCA, but the control arm is GemNab-P. And that's going to be an important study and may define a second-line space. So I'll move on to KRAS-directed therapy, and just this is a disease of RAS, right? 92% of people will have a RAS mutation. Majority are G12D, followed by V and G12R. So if you ever see a G12R mutation, it essentially can only be pancreas cancer. We see it very, very rarely in any other disease, and a little different in terms of outcome. 1% of patients, plus minus, will have KRAS G12C. So what do we know about RAS and pancreas cancer? In that it is prognostic, that is clear. G12R may have a better outcome. G12D tends to do less favorably. And we see G12D enriched in patients who are diagnosed with de novo metastatic disease. And this matters because we're now, firmly in the KRAS-directed therapeutic space. There are lots and lots and lots of drugs being identified, as you've heard in lung. We didn't touch on it much in the colorectal cancer setting, but very relevant there. Looking at direct RAS targeting, indirect RAS targeting, downstream, upstream, looking at protein degraders, which are a very interesting new class of drugs, and looking at vaccines targeting RAS. So a lot coming. And KRAS G12C, there are now 5 data sets that have been publicly presented in pancreas cancer, and they all demonstrate the same thing. Most of these patients were in a third-line setting, but not all. That response rates are real, 20 to 30 to 40%, with a median PFS somewhere between 4 and 6 months for most of these. These are single cohorts, so not compared to chemotherapy. But these drugs can work. Of course, resistance is real, and we're just at the beginnings of learning what combinations will have relevance in pancreas cancer, including some of the ones that are already being studied in colorectal cancer, and including, which I think is likely to be a key consideration in pancreas cancer, will be combining with chemotherapy, but we don't have data yet to speak of that. So just going to show you one slide on one drug, and that is RMC-6236. These data were presented at the Triple meeting last year and ESMO. This is an oral pan-RAS inhibitor that's in development in pancreas, non-small cell lung cancer, colon cancer, and other malignancies. And this is the summary slide for the initial 46 patients with pancreas cancer. And again, these were all heavily pretreated. And you'll see, again, very real downward waterfall plot with objective responses in lung, in liver, in non-liver and peritoneal disease, manifest clinically, manifest by CA19-9 changes. So that's exciting in pancreas cancer. It's exciting. So we're going to be seeing a lot more to come. And in the last couple of minutes, just in view of time, I'll just spend a couple of minutes on immunotherapy. So back to an old topic in a way in pancreas cancer, and looking at T-cell therapies in this disease. They have been looked at, and there are case reports published in high-impact journals showing an ability to induce an immune response and an objective clinical response in metastatic pancreas cancer. But T-cell therapies are labor-intensive. They are very selective in both the RAS mutation and in terms of HLA subtype. A lot of logistic considerations and maybe toxicity considerations, so not necessarily scalable for most patients. And with that, we've had some data, and this trial is interesting for multiple reasons. It was a study that utilized ctDNA in an MRD positive space, so patients who had completed early stage treatment for localized pancreas cancer, so they resected, had their adjuvant or neoadjuvant treatment, and had either a rising biomarker or ctDNA positivity, and were given a KRAS vaccine. This targeted G12D or R, so they had to have either of those alleles for eligibility, and was looking to see, could you do this? Is it safe? Is it feasible? A lot of data here on this slide, but just to explain the key points, that this was very safe. It was very well tolerated. It was a sequential vaccine given weekly for 4 weeks, then every other week as part of the priming phase, then a pause period, and then a booster period. But what was interesting and encouraging is that some patients had clearance of their ctDNA and had clearance of their, or decline in their CEA or CA99, suggesting that something oncologic was happening. And there was additional data showing that those who generated a potent immune response, when you segregated by above median or below median, there was a difference in outcome in terms of relapse-free survival. Now, lots and lots of caveats. This is early, and it certainly needs validation in a larger data set, and that's what's ongoing. This is a randomized phase 2 that's ongoing using a next generation version of this vaccine, which covers the G12 and G13 KRAS and NRAS alterations, so all the major alleles that are present in pancreas cancer. And it's a nice design, so after completed all your standard therapy, kind of agnostic to that, as long as you're NED and within a certain time point and have one of these alleles, you're eligible for randomization to the vaccine or observation, with the possibility for crossover for those in the control arm. So that's one piece of data, and then just in the last minute here, just to present the second piece of data, which was a trial led by Dr. Balachandran, one of our colleagues at MSK, which looked at a different immune-based approach using a personalized neoantigen vaccine approach, a vaccine developed from tumor tissue from patients who'd undergone resection, and using an mRNA platform vaccine, identified the 20 most promising neoantigens using 2 different algorithmic approaches. And then this was administered post-op with a dose of atezolizumab, followed by standard therapy, followed by 1 booster dose. And the outcome was very similar. This was safe. It was feasible. I wouldn't say, it's without logistical challenges, but it was definitely doable. And this, again, once more, demonstrated a very potent immunologic signal. And for those who had a high immune response, their relapse-free survival was significantly better and not met compared to those that didn't generate an immune response. And that's also being tested in this randomized phase 2, which is underway for patients who have resectable pancreas cancer who undergo resection. And really, patients need to be identified ideally pre-op, but can be very early in the post-op period. And then it's a 1-to-1 randomization for this personalized neoantigen mRNA platform vaccine with atezolizumab, followed by chemotherapy, and then boosting relative to standard modified FOLFIRINOX. So we'll see. So 2 studies showing similar signals, both being looked at, both of different designs in a randomized phase 2 setting in pancreas cancer.
Like it a lot. At least them very different and exciting. So wow, thank you so much. Thank you. It's been such a pleasure and an honor to work with you this weekend. Have a great day.